So as mentioned, I'm a pediatric neurologist. So my experience working with people with multiple sclerosis has been from the childhood point of view. I had a lot of my training between Montreal and Toronto, so I did see a lot of children with MS ranging from infancy to their teenage years. And the topics I'm going to be discussing with you today are going to pertain a little bit to children, but more to the young adult population. But please feel free afterwards to ask me questions about any age range, anything you want. You don't have to stick to whatever we're discussing within the topic. So the first thing I want to point out, as you all well know, is that MS affects the family. And MS is not an illness that affects the young Caucasian woman anymore. That's how it was perceived years ago. This is an illness that affects any ethnicity, any age group, and it not only affects the patient, as you have just heard, it affects the spouse, it affects the parents, it affects the kids, it affects the siblings, it affects everyone involved. So it's real, in this family, you would not know which family member has MS because any of these people could have it. So what I want to do over the next half an hour is describe how MS can present in children and young adults. And we're going to discuss mainly the issues of being pregnant and becoming pregnant if you have the diagnosis of MS, what the risk is to your family members, and then make some suggestions on how you can modify your lifestyle a little bit to decrease your risks. So as many of you are aware, multiple sclerosis has different disease courses. And at the very beginning, it's hard to know which course you're going to take. But the majority of people with the diagnosis of MS will take the relapsing remitting course, meaning that they'll have clinical relapses or new lesions coming in on their MRI that come and go over time. And it's unpredictable as to when they're going to come, and it's unpredictable to know where they're going to come and when they're going to go away. Sometimes these relapses need treatment, sometimes they don't. And it really depends on how each relapse affects you. After a certain number of years, a lot of people do go into the secondary progressive phase where those relapses go away, but there's this underlying progression of the disease with time. This also, we don't know when it's going to happen when a person is diagnosed with it. Rarely we have people that start off with a primary progressive problem where they don't get the relapses, but they just accumulate disability after their first attack. So we do know that MS does happen in children, and in Canada, along with many countries around the world, there's been a shift in a lot of research being done in children with MS. We know that when a child gets affected with a disease, that it's probably happening sooner from when the biology has started within. So we're getting a lot of important information from actually studying kids that have this disease. So a lot of studies have been done in a national way to try to get data to find out when it happens and what kind of presentations kids have compared to adults. So we know that the first attack happens on average in 1 out of 100,000 people. And about a quarter of those will likely have a second attack and be given the diagnosis of MS. This doesn't sound like a big number, but we know a lot from retrospective studies as well that at least 5% of adults that have a diagnosis of MS probably started in their childhood years before the age of 18. It's just at that time they were probably not thought to have MS because MS wasn't thought of as a disease of children. Actually, in the past, if you're under the age of 10, it was in the diagnostic criteria that you could not have MS. That was an exclusion criteria in the past. Of course, that has changed. The presentations are very similar to that of adults. So the most common presentation in children and adults is the loss of vision, and that's due to inflammation in the nerves, the optic nerve, and it's called optic neuritis. You can have sensory changes, meaning you can have numbness or tingling in an arm, leg. You can have difficulties with strength, so you can have some weakness in a limb, difficulty walking. You can have problems with your bowel or bladder, dizziness, eye movement changes, problems speaking, and sometimes multiple things can happen at once. So it's very variable, and you can't tell what kind of symptoms someone's going to have based on how they look or anything else from their past. So the presentations we see in kids are very similar to that of adults, and sometimes in kids we also see a lot of behavior changes that go along with it, especially in the younger kids. And sometimes their MRIs will look quite a bit different from what you'd expect in an adult. I'm not going to go into more detail than that today because for the sake of time I want to go into some other topics. So as mentioned, at diagnosis it's hard to predict which course a person's going to take. But it seems that if you're diagnosed in childhood, you probably remain physically stable for a longer period of time, on average 10 years longer than an adult is. And this doesn't mean there aren't other issues going on, but just in terms of physical ability, it seems to be longer before you hit that secondary progression. So there are a lot of issues that pertain not only to kids and adolescents, but also to young adults. And in the teenage years, of course, you're going to school, you're learning, you're building your foundations, a lot of your neurons are interconnecting, you're building these networks, and your cognitive skills are going up. And if you're disrupting this by having attacks on your nervous system, then that can really inhibit the way you're learning. You also have to deal with fatigue and energy levels and change in sleep habits. Your physical activities may not be the same because you don't have the energy to do them, or you may be afraid that if you do something, you might actually provoke an attack. Your relationships with your peers may change. This is the time when people are socializing, developing relationships. You may be fearful that somebody's going to find out. You may not want to have that same interaction with other people. Your mood may be affected, also affecting your socialization. You also are taking medications, and we give medications in kids just like you do in adults, except we don't at this point offer any of the oral therapies to kids. So all the therapies that are offered are injectables. And you can imagine how difficult it is for a child to take a needle, or a parent to have to give a needle to their child every day or every week. So there's a lot of counseling that has to go on up front to say, this is a family, there's not one parent against another parent trying to give a medication to their child, showing kids modeling to kids how to give medications, trying to prevent the fear that goes along with medications. The side effects are a problem. There are lots of things that have to be dealt with quite differently when you're dealing with a child or a teenager who has MS. But it's important to know, if we make the diagnosis early, we can offer treatments, just like we do in adults. The treatments are just the injectable ones at this point, though. So we know well that females are affected more than males in the adult years. We also see that in children. We see that after puberty usually. Before that, we see that males and females are affected quite equally with the diagnosis. After puberty, we see that ratio change, and females are affected about 2 to 1, 3 to 1 compared to males. Why that change, we don't know yet, but there are lots of theories underlying it. So the first topic I want to take from there is about pregnancy, and there are lots of questions that surround pregnancy. So things that people think of, and this is not just the woman getting pregnant, but these are also thoughts that go through the partner as well. First of all, can you get pregnant? Can I take my medications when I'm pregnant? Will I have more relapses during pregnancy? Can I deliver my child normally like everybody else? And then after you have the baby, there are more questions. Should I be taking my medications? Can I breastfeed my child? Will my child now be at increased risk of developing MS because myself or my partner has MS? Am I going to have more relapses after the pregnancy, after I deliver? So let's go through some of these things. And the first thing I want to ask you, just to make this a little bit interactive, do you think MS affects your fertility for males or females? How many people say yes? How many people say no? And how many people are not sure? So yes, you're correct. MS does not impact your fertility in men or in women. So what we do know is that if you have IVF therapies, though, you should be off your medications. During IVF, the types of therapies that are given can increase your MRI lesions and your relapses. And in combination, because you're not on your medications, you may have more activity in terms of your disease. There are also some therapies, second-line therapies, that can affect fertility, but these are not the common first-line therapies that we use for MS. And these are discussions to have with your physician, and these are things that would be explained to you in terms of side effects. The other important topic is that MS can cause sexual dysfunction in men and women. And this is a topic that some people need to approach with their physician if they're not asked, because of course this can also impact your ability to conceive. So please feel open, because all physicians should be able to have this discussion with you and offer you advice on as to what to do if this is something that's affecting you. One important thing to know is if you do get pregnant, there is no increased risk of miscarriages if you have MS. So the next question is, you're pregnant now. Can pregnancy make your MS worse? Is this true? False? I don't know. So no, pregnancy doesn't make your MS worse. The first thing you need to do, and I'll explain why, is you need to tell your physician that you plan on becoming pregnant or that you want to try. Because it's recommended that you're not on any of the MS therapies while you are conceiving. So the recommendation is that 3 months prior to conceiving, you should be off therapies for females, and for males with one of the new oral agents, they should also be off their therapy for 2 to 3 months, specifically with teriflunomide. And it's best when you're trying to conceive that prior to that pregnancy, you are at the best health you can be. Because pregnancy is hard as it is for any woman. So you want to be as strong as you can be physically, mentally, have the supports in place before you go through this so that you can get through this as strong as anybody else. Once you are pregnant though, you do not have to be followed in a high-risk clinic. You are considered like everybody else. So there are hormonal changes that occur during pregnancy. And things that change as pregnancy goes on include your levels of progesterone and estrogen. And estrogen, more than progesterone, appears to have a role in its capability to modulate how you react with your MS. So both of these, as you can see, after 4 to 5 months go up pretty high. And after the delivery, they go back down to where they were before. So the first episode, your first attack, is unlikely to happen during pregnancy. And so those who are worried that they have family members that have MS and they're worried that they're pregnant now, what if it happened now? The likelihood is very, very low that that first attack will happen at that time. Your MS disease actually remains really stable during pregnancy, and if anything, your relapses are going to be less during pregnancy, especially during that second half of pregnancy. So why? Why is the risk lower during pregnancy? So we're just going to talk very briefly about our immune system and talk about the immune cells. So to simplify things, there are the good guys and the bad guys. The good guys are these Th2 cells, which are more anti-inflammatory, and the bad guys are the Th1 cells, which are more pro-inflammatory. So in general, when you're pregnant, you're carrying this foreign body inside of you. You're carrying this fetus, and you don't want to attack your own fetus. So what happens naturally is that the woman's pro-inflammatory cells go down, and the anti-inflammatory cells go up. So in the process, you're protecting your fetus, and at the same time, you're passing on your immunity to the fetus so that when your baby is born, your baby is strong. So in the last half of pregnancy, you're actually overall in an anti-inflammatory phase. So this is actually very similar to being on one of your therapies. So pregnancy pretty much mimics being on one of your disease-modifying therapies. There are also some other hormones that go up, including cortisol, which are steroids, and vitamin D that seems to go up in the last part of your pregnancy, and these are also thought to be protective. So if it helps to have more estrogen in your body, does that mean becoming pregnant more often is going to be protective overall? Does that mean taking an oral contraceptive pill is going to be protective overall? So It's unclear. Will multiple pregnancies slow down the progression of MS? At this point, it's unclear and probably not, because what's happening is you're having this transient immune modulation or anti-inflammatory effect. It's like you're taking your medications short periods of times when you're pregnant, but overall, in this whole scheme of things, it's not a continuous thing that's going to keep treating you, right? You're going through phases. So it's probably not going to help your overall prognosis at the end of the day, but during that period of time, yes, it is beneficial for you. The hormones as well may affect your relapses, but it's unclear whether it affects that progression, that progressive phase, because remember, MS has two components to it. It has this inflammatory phase that's causing those relapses, and there's that progressive phase underneath that's due to probably something different, because our therapies right now are really targeting the inflammation. We don't have therapies right now to target that progressive phase, unfortunately. So although people are working on that end, the hormones seem to be working, at least the estrogen and possibly testosterone. Estrogen, is working more on the inflammatory phase. And there are some studies going on looking at testosterone to see whether it can help prevent that progressive phase as well. So will the pill affect my risk of progression of MS? So the amount of estrogen in a pill is quite low in the estrogen-only pills, so it's probably not high enough to make an effect. And higher doses continuously are not good for the uterine lining. You need a little bit of mix of progesterone and estrogen. But there are studies looking at high dose, medium dose, low dose, and there does seem to be some impact in terms of MRI lesions and clinical relapses, and these are just recent studies. So maybe we'll find out more in the next 5 to 10 years about estrogen, its role as a treatment on its own, or maybe in combination with other treatments. So what if you do relapse? Because there's still that small chance you're going to have a relapse during pregnancy. So what if you relapse? Can you get treated the same way as before? So steroids aren't generally recommended, because steroids at the high doses that you get treated with may have effects on the baby. So it's probably better to avoid using steroids unless you really need it. If you get a relapse that's physically disabling and you need to be on your feet and you know that you can't cope without getting some treatment to make things go away faster, then yes, steroids can be given, but they're usually reserved for those more severe cases. And if you get symptoms, should you get an MRI? Although MRI is not radiation, it's probably safe. It's probably not necessary to be done if you know that the symptoms are going on or related to the MS. And also sometimes we give a little bit of contrast to look for active lesions. That's not recommended when you're pregnant. So what happens at the time of delivery? It's important to know there's no increased risk at delivery. You can still deliver vaginally, you can still deliver by C-section, depending on your medical, like your state. Whatever is necessary, and there's no harm doing either. And anesthesia, including epidurals, is safe. There's no change if you have MS or not. So after the delivery, there's lots of questions. So we know that there's also a higher rate of relapse, especially in the first 3 months, and then you go back to the pre-pregnancy rate. Now that higher rate of relapse it is higher than during that pregnancy, but it's probably more related to how you were before you got pregnant. So you're kind of going back to that relapse rate from before. And there's no other risk factors known for who's going to relapse right after delivering and who's not. So it is important to know that it can happen after, because you're having this sudden dip again of all your hormones. So you're going back into that different state, and that change does put you more prone to having a relapse. So the chance of relapse goes up in the first 3 to 6 months, and there is a good chance there's a relapse in the first 9 months. There's also the chance of postpartum depression, and I'm mentioning these things because it's important to know about this so that you're prepared for this, so that you don't ignore the symptoms and others don't ignore the symptoms. And this is a risk for anybody postpartum. So if you've had symptoms before, it's important to just think about them a little bit more and have your supports ready. If you have a relapse as well, it's important that you have somebody, whether it's your spouse or your partner or a friend or a parent or somebody around, to help you take care of the baby during that time, because it can be difficult if you have a relapse if you don't have another pair of hands around. So another question that comes up is, can you breastfeed? So during breastfeeding, there are other hormones that increase, including prolactin, and that's something that's also there during pregnancy. And it may be protective, but breastfeeding or not, it doesn't seem to impact relapse rates. So you may choose to breastfeed, and that really depends. It's a personal decision. It depends on what your MS was like before you got pregnant. If you're at a really increased risk of having a relapse, then you have to weigh the pros and cons. Is it better for me to breastfeed, or is it better for me to decrease the chances of a relapse and go back on my medications? So that's a discussion that has to be had with your physician to make that decision, because there are risks and benefits to both. So once you have your baby, what are the risks that your child will get MS? So the risk is higher, but it's not very high. So it is much higher than at the baseline population, 2 to 4%, and it depends if mom has MS or dad has MS. The risk is a little bit higher if mom has MS. And if both parents have MS, then of course the risk goes even higher. But we don't know 15 years down the road if your child develops MS. The treatments can be quite different. We may even have a cure. The disease course could be different. There's a lot of variabilities there. So it's something that may happen, can happen, but it doesn't have to dictate how you deal with your life, because if it happens, we can be in a completely different situation a couple of decades down the road. If you think about it, thinking back to the 90s when there were no treatments, that was only 20 years ago, in the early 90s. So we've come a long way since then, and we can still come a long way in the next couple of decades. So if you have a family member with MS, it's another question that people think of. If you are an identical twin, the risk is pretty high, but it's not 100%. So this is telling us obviously that there's more than genetics to getting MS. There's obviously a lot of environmental genetic connections that are going on. If you're a non-identical twin, the risk goes down quite a bit, almost to the same risk as just having a sibling who has MS. So can you prevent any of these risks if you're a family member? There are no known ways to prevent. There are certain risk factors that we know that are present in, for example, in kids, such as low vitamin D level before that first episode. So we do encourage vitamin D in all of our patients. And there are genetic factors, and some of them are protective and some of them are risk factors, but you can't control that. So nothing is absolute. And remember, as I said, things can be different. So even if you think you're at risk, things can be different if and when you have symptoms. So what can you do to modify your lifestyle a little bit? So there are risk factors that are non-modifiable, meaning you're born with them, such as if you're male or female, your genetics. And then there's those that are modifiable, meaning things that you're exposed to, vitamin D and sunlight, physical activity, your diet, your weight. So one thing I can say very clearly, there have been lots of studies saying that smoking does increase your risk of MS, whether it's you smoking or you're in a household with smoking. So kids who grow up in a household with parents smoking are at a higher risk than kids who do not. And that's very clear. So if you smoke, then stopping smoking is obviously a good thing for many reasons. Vitamin D is something that's out in the media, that's something that's very talked about very much so nowadays. So we know that MS has a latitude gradient, meaning that if you, in countries that are further away from the equator, south or north, there's a higher incidence of MS. So Canada does have one of the highest incidences of MS in the world. Vitamin D levels in children are lower at the time of first attack. So is that because we're not exposed to enough vitamin D? Is that because our parents weren't exposed? There are a lot of different things a lot of different theories as to why vitamin D could be part of it. But we know that vitamin D has effects on the immune system, and we know that there are vitamin D genes that have interactions with the immune system as well, and also have interactions with some of the hormones we talked about. So in terms of exercise, everybody knows this. Exercise can improve your strength, it can improve the way you think, it can prevent obesity and cardiac disease, and it's important that we do take care of the rest of our health, so that we're not developing high blood pressure, diabetes, cardiac disease, all of these things that can affect your physical well-being. Exercise improves your energy level and it improves your mood. So it's pretty much a no-brainer that exercise is good. But some people do worry that physical activity, especially heating up the body, can cause a relapse. So I just want to clarify what's a relapse and what transient symptoms are. Because once you have, so when there's heat, your nerves conduct at a different rate. So if you get really hot, for example, going into a hot tub or a sauna, you can get symptoms that you had before. And that's because the nerves that were affected, you don't have the same reserve that they had before. So some of the old symptoms can come back temporarily. But those symptoms will go away. And they're not symptoms such as in a relapse, because in a relapse they'll last for days, they'll last for weeks, and they're usually not the same symptoms you've had before. So there is a difference between a relapse and these transient neurological symptoms you can get. But in general, advice is avoid extreme heat, avoid extreme cold, and just do regular physical activity. There are a lot of questions regarding diet and obesity. So there is no diet known right now that can help treat MS. There are lots of research going on between the gut neurons and our brain neurons, and are there effects that we can have on our gut that would help our brain. But we don't have a diet at this point that can help. But we do know that obesity actually is a risk factor for a future diagnosis of MS, because in the cells, the fat cells, there is actually more immune activity, immune cell activity. So something to exercise, keep a proper diet, keeping your weight down is actually very beneficial. And there are lots of alternative therapies, and there's nothing wrong with looking at alternative and complementary therapies, but the first thing is that you're not doing harm to yourself in any way. So if you're looking at supplements, boosters, make sure you're not looking at therapies that are actually going to affect your immune system. Because if you're on a medication, that can be counterintuitive. It might actually be giving you the opposite effect of what of your medications. And remember, MS is a problem with the immune system, but it's the way the immune system is regulated. We think there's too much inflammation going on. So you don't want something that's going to boost your immune system, because that's going to make things worse. So it's really important, if you're thinking about taking other medications, vitamins, anything, that you just discuss it and have a frank discussion with your practitioner, just to go through its effects and interactions with what you're on now, and just to know a little bit more as to whether it's safe or not. Because primarily you just don't want to harm yourself anymore. You want to obviously make yourself better. So, in summary, MS can present in a young adult, it can present in a young child, but you can pretty much live the life you want to live. It's just important that you take care of yourself. And what I tell everybody is, take care of your brain, take care of your heart, and then in essence you'll be taking care of your MS. Because everything that's good for your heart, exercise, diet, weight regulation, all of that is good for your MS, of course, as well. So that's all I have to say.